Hi friends, I am Dr. B.B. Rao of Usha Clinic and founder of the website qmedicaldoubts.blogspot.com and raghavamedicaldoubts.com. Through these videos, I am providing the basic knowledge about the commonly occurring diseases, treatment and surgery details when necessary for the medical knowledge to general people and for reference to medicals. Today I am going to discuss about the carcinoma of prostate. In men over the age of 65 years, the carcinoma of prostate is the commonest malignant condition. Prostatic obstruction cases are usually due to carcinoma, besides other causes. It starts in the following ways. In the posterior zone of the normal gland, diffusely in one or other lateral lobes, in association with benign enlargement. Prostatectomy for benign enlargement of the gland confers little protection to the subsequent development of carcinoma. Latent carcinoma of prostate. In the prostatic serial sections obtained by the aged above 50 years revealed carcinoma in the organ are obtained. These neoplasms are tiny and might have remained latent for years. In men over 90 years of age, 75% of the prostates are involved. It seems that there is a seedling carcinoma often present in the prostate of an elderly man, awaiting favorable conditions to become active. Non-latent carcinoma of prostate. Usually the prostatic carcinoma is a spheroidal cell carcinoma with a varying degree tubule formation. In that case, the tumor is a slowly growing one. The anaplastic type is more malignant and manifests itself more aggressively than the adenocarcinoma. Local spread. A growth commencing in the posterior zone of the gland is prevented from extending backwards by the strong fascia of Dinovilliers. So it tends to grow upwards and involve the seminal vesicles. Further upward extension obstructs the lower end of one or both ureters and cause anuria. Carcinoma starting in the lateral lobe involves the prostatic urethra early. In advanced cases, the base of the bladder is invaded. The rectum is involved occasionally by infiltration and stricture of rectal wall occurs. The mucosa does not ulcerate unless traumatized. Spread by bloodstream. Prostate is the most common site of origin for skeletal metastasis, followed by breast, kidney, bronchial tree and the thyroid gland. Pelvic bones. Pelvic bones and the lower lumbar vertebrae are particularly common sites. Lymphatic spread. Via lymphatic sites, vessels passing along the sides of rectum to the lymphatic nodes along the internal iliac vein and in the hollow of the sacrum. Via lymphatics, which pass over the seminal vesicles and follow the vas deferens for a short distance to drain into the external iliac lymph nodes. From both these places, the retroperitoneal lymph nodes and later the mediastinal lymph nodes and occasionally supraclavicular lymph nodes are implicated. Clinical features. The patient is present with acute or chronic retention of urine. The types are pathological, resemble that of benign growth. Histological examination contains one or more areas of carcinoma. Type 2. Clinically doubtful symptoms resemble that of benign prostatic enlargement. The history is comparatively very short. A hard nodule or increased fixation of the gland favors the diagnosis of carcinoma. Type 3. The clinically certain The patient complains of pain in the perineum or suprapubic region The rectal examination diagnosis is confirmed. Rectal examination. Irregular induration, stony heart, and decreased mobility suggests carcinoma. Sometimes the rectal mucosa may be left to be tethered to the back of the prostate. By infiltration of the carcinoma, obliteration of the notch between the seminal vesicles or of the groove between the lateral lobes adds to the suspicion. If the induration extends beyond the lateral limits of the gland, causing obliteration of the lateral sulci or to the membranous urethra, the diagnosis is certain. Prostatic calculi and Kairos changes secondary to tuberculosis of seminal vesicles present the greatest difficulties in diagnosis of the prostatic carcinoma. In case of doubt, examination under anesthesia may be help. Type 4. The occult urinary symptoms are absent or slight. Pain in back or sciatica is the main symptom. Bilateral sciatica in an elderly man is most often due to the metastasis in the spine from the carcinoma of the prostate. Edema of one or both legs, paraplegia or spontaneous fracture, or occasionally due to metastasis from the carcinoma of prostate. Anemia may be present due to destruction of bone marrow. Bone metastasis from the carcinoma of prostate can give rise to a hemorrhagic diaphysis, and the patient suffers hemorrhage, often severe, from the urinary tract. Other aids of diagnosis. Serum acid phosphatase. The acid phosphatase raised above normal, 1 to 3 king angstrom units. A reading between 3 to 5 Ka units is suspicious of carcinoma, and above 5 units is diagnostic. In patients with metastasis, 10 king angstrom units by 100 ml of serum is common. Exfoliate cytology. Prostatic massage. The patient stands with the legs apart, leaning forward and studying himself with one hand resting upon the examination couch. With the other hand, he retracts the prepuce. 4 slides duly numbered are placed in readiness on the couch. Prostatic massage is conducted in such a way as to avoid compressing the seminal vesicle. 4 drops are collected separately. In this way, contamination with seminal fluid is avoided. Each slide is covered with another similarly numbered. Each pair is slide apart, leaving a film of secretion upon it and keep on fixation fluid. Procuring a prostatic smear for cytological examination should not be conducted within 3 days of a diagnostic rectal examination of the prostate. Pathologists confirm the presence or absence of carcinoma cells. Biopsy. The types of biopsy in practice are needle biopsy, open biopsy, and transurethral biopsy are in practice. Needle biopsy. Circles or similar instrument is passed into the tissue of doubt. The cannula is removed and the trapine is passed through the needle and directed to a suspicious needle and collected the specimen. Open biopsy. Formal biopsy through an inverted U-shaped perineal incision is believed to be the best. A wedge of tissue obtained in this way gives the pathologist more scope in doubtful cases. Transurethral biopsy by cystourethropy. If there is a history of hematuria, this is essential. There is often a grating sensation as the prostatic urethra is traveled. With the instrument in the place, a deep induration, the prostate is more readily appreciated by a finger in the rectum, and fixation of the gland becomes more evident. Pucking of the apex of the trigone, submucous nodes in the base of the bladder, or ulceration of intravesical projection or late manifestations. In earlier cases, there are no pathognomonic visible signs. Biopsy. Transurethral dissection of the prostate has the advantage of removing the obstruction and providing large pieces of tissue, but it may not reach the posterior zone of prostate, which is commonly the seat of early carcinoma. Vesiculography. In very early cases, a distortion of the topography of the ampulla of seminal vesicles is extremely suggestive of carcinomatous infiltration. Bone marrow aspiration. In aspirations of the sternum and ileum reveals the metastatic carcinoma cells. In a high percentage, those cases where radiological examination could not reveal the secondary deposits. It is carried out in every case before radical prostatectomy is considered. Treatment of carcinoma of prostate. In spite of all investigations, it is confirmed only in late stages. Radical surgery plays a small part in the management of the condition. However, a great deal can be made to alleviate the symptoms. Silvestrol. It causes improvement in 85% or more cases. Histological changes in many malignant cells may be apparent within 48 hours of commencing treatment. The cells distended with glycogen nucleus becomes pycnotic and moves to the edges of the cell and extended when the cell breaks up. There is less dysuria, better stream, less frequency, and aches and pains may disappear in 2 weeks. The prostate becomes smaller and softer in about 4 weeks and identified by rectal examination. Bone deposits may become static or disappear. Dosage 25 milligrams 4 times daily. Side effects of stilbestol: gynecomastia and deep pigmentation of nipples. Impotence is variable. Nausea and gastric upset. Edema of the ankle from salt retention. Excess nasal secretions and visual disturbance. Adrenal stimulation and elevating the androgen secretion may occur. Alternatively, TACE, tripara-anethylchloroethylene, at the dose of 12 to 24 milligrams may be tried. Dienestol, considered to be better than stilbestol, used at a dose of 45 milligrams daily by mouth. Horn-Van phosphorylated diethyl stilbestol. It is given intravenously at first 100 milligrams is injected very slowly 3 times a day for 10 days. The dose is then increased to 200 milligrams to as much as 500 milligrams to 1000 milligrams till 20th day. The dose is then gradually decreased till 200 milligram injection weekly and finally monthly. It may have liver damage as a side effect. Treatment of retention of carcinoma. Acute retention. As carcinoma of prostate should be treated with indwelling Gibbon catheter and stilbestol 25 milligrams 4 times a day for 2 weeks. Usually, micturition will then be resumed. If after 3 weeks the patient can't pass urine normally, then the obstruction should be relieved. This is usually done by a transurethral resection. But if the gland is also the seat of adenoma, a retropubic or a transvesical removal of the most tissue may be considered. Chronic retention. In this case, the catheterization should be avoided if the urine is sterile and first seal. Infection once started is impossible to eradicate in presence of growth. The residual urine may gradually decrease by treatment. If not relieved, pre-urethral resection may be necessary. Radical surgery for carcinoma of prostate. Total prostatectomy is needed. There are two types. MILLIN'S method, retropubic approach, or Young's method, perineal approach. After the prostate is removed, the membranous urethra is anastomosed to the base of the bladder. It allows to perform a biopsy as a preliminary part of the operation. Treatment of pain and enlarged lymph nodes. Severe pain from the bone, secondaries, and perineal lymphatic infiltration is difficult to control, as is edema of the leg from the enlarged lymph nodes. Deep X-ray therapy combined with intra-arterial nitrogen mustard given into the pelvic vessels via a retrograde catheter up to the femoral artery. 2 doses of 15 milligrams at weekly intervals is beneficial. Pituitary ablation is beneficial. Adrenalectomy is sometimes tried with questionable benefits. That's all about the prostate and its neoplasms. And in the next video, I will discuss about some other disease